My name is Stephanie Shaw. I am a U.S. Army veteran. I deployed to Afghanistan in 2003. I am married to a veteran, U.S. Army veteran. He went to Iraq in 06-07. We have 5 children together, so we are a very patriotic military type family. I have been in the arena of veteran services supporting military families since 2010, and originally through deployment cycle support with the Mass National Guard Family Program Office throughout all of the western half of the state. I spent almost 4 years in Worcester County supporting the Guard units in that region. And then I also spent another additional 4 years in the Springfield office supporting the 4 counties of Western Mass through their deployment cycles. And there's a lot that goes on in a deployment cycle. The pre-deployment, the actual deployment, and then the reintegration in post-deployment is often the hardest. And now I've been the Director of Veteran Services for the city of Chicopee for 8 years. And the biggest element of my day, I would say predominantly, is assisting veterans accessing federal benefits like VA claims and enrolling in VA healthcare. So I would agree that personally and professionally, I have a lot of experience in that integrated world of quality of life and health, specifically within the military and veteran community. Somebody thought I couldn't do it, and I said, watch me. I wish I had a better answer. Nothing patriotic. My family's all Canadian. Nothing to do with the U.S. military. My boyfriend at the time was in it, and he was talking about it, and I said, oh, that sounds cool. And his dad said, you never could. And I said, so I called his recruiter, and I said, what's the hardest job a female can do? At the time, he told me military police. I was naive and believed him. Mostly, I think he just needed a quota in that MOS. But that's what I did for 6 years. I'm currently married to my second husband. I was married to my first husband, who I met in that military unit, and he had more time in, and I hit my career, and we wanted to have family. So when I ETS'd to have kids, he stayed in. ETS? End of term of service, enlistment term of service. It changes over the years. So I did my 6 years. It got out. He stayed in. He deployed to Iraq in 09 to 2010. We had a daughter at the time. I was pregnant with our son when he left. I had him in January during that deployment, about halfway through. So personally, I lived that deployment cycle as like a single mom and mom of a newborn, postpartum and all that stuff. And then we separated and got divorced, and then I remarried my current husband, who happens to be that high school sweetheart who I thought what he was doing was so cool, in 2013. So I've served and done the deployment cycle support, but not with my current husband when he went to Iraq in 06-07. There's a lot of things. It's just we here in Western Mass, we don't have an active duty base. We don't belong to a very closed captioned community where everybody understands what's going on, everyone knows what's happening, everyone knows the cycles, everyone knows which units are leaving. So for example, when my first husband was leaving, I had a dental, I won't call it an emergency, but I ended up with an unexpected appointment, and I was pregnant, so add all that into it. And I remember just bawling in the dental chair because of everything that was going on, and I already didn't like the dentist. And not being on a base, I wasn't at a military medical facility, so they were just a little caught off guard, and I think they blamed it mostly on the hormones of the pregnancy. Later in that same deployment, I had an eye exam, and again, that lack of culture. The optometrist scolded me because I took a phone call out while I was in the waiting room. Well, it was my husband who was overseas, who I never knew when he was going to call. And he strongly reprimanded me for how unpolite I was and disrespectful to his practice, that I would take a phone call when his, there's a big sign that says. And I came back and I said, well, my husband's currently in Iraq, and I don't know when he can call, and his time is more important than yours. And he didn't like that answer, but he changed his tune. And again, I credit it to just not being in that very closed circuit community of being on a military base and just being in the community at large. And there's a lack of empathy, a lack of general awareness, right? Because we're not on a base, so they don't know. I could be anybody. I could be anybody's wife. It doesn't matter to them. It's all about the insurance and the money and next patient, next appointment. So I didn't blame them for it, but I made sure to educate them when I was going through things. I knew, because of my professional experiences, to educate the medical teams for all of my kids. I think their awareness is imperative when you're dealing with a family on active duty or through an active deployment, just because there's a lot of uncertainty, there's a lot of unexpectedness, there's a lot of emotions. Scheduling can change last minute. Having the phone on in an appointment typically is not, encouraged, but when you're dealing with a family in a situation that, they get to call once a month and you don't know when that is, I think that knowledge allowed them to be more sympathetic and empathetic and a better care provider. But there was no way for me to expect them to have that information or know that about me without me sharing it. They certainly didn't ask. Most of the people I work with when it comes to understanding the relationship with service and health, not to get into the weeds, but there are the presumptive conditions based on certain exposures, for example. VA healthcare is not good, but getting better about educating VA healthcare about benefits within the Veterans Benefits Administration. They're two entities that don't talk. They don't cross-train until the PACT Act in 2022. Then they started to share information and those awarenesses about toxic exposures. What happens, and the reason why I think that's important, is because, for example, if you're dealing with somebody in their 70s and they're dealing with diabetes, there is no reason for them to tell you they were ever in the military. But in VA healthcare, their service is flagged as an exposure for this related federal presumption, and that warrants free healthcare. That warrants compensation benefits and all the ancillary benefits that go with that. And there's nothing in VA healthcare that triggers a relationship to VBA, except for the flag in the file that says there's a toxic exposure risk assessment done. This is the exposure, these are the associated presumptives. And there's nothing like that for someone in the private sector to make that correlation, unless they've personally gone out and been educated on it or have a personal relationship with a veteran with that particular exposure, most likely. I think it's an ignorance of the value of sharing that information. When you go to a provider, they ask you, are you safe at home? Are the utilities on? All these things to see how you're doing as a whole person. But if I meet a Vietnam veteran, I know when I'm talking with them, because I know the presumptives, what are you dealing with? What do you have? Hypertension, diabetes, prostate cancer, Parkinsonisms. I know to screen them for that because it allows them to advocate for their health care better. So often, many of these conditions present so mildly in the beginning, and there's nothing in a civilian network to trigger a screening early on. Because if they understand that they have a susceptibility to these certain conditions that can be fatal, early diagnosis is almost always the key. And they're missing that opportunity by not having that information to better treat their patients. And if the veterans don't know and the medical professionals don't know, it goes downhill from there. Well, I think there's a lot of misconceptions with VA because they're really, that management oversight isn't there. But what happens, and we're trending sociologically in that direction of more electronic records, because what happens within the VA healthcare system is not insurance. It's a healthcare network. And that means your file is accessible by the network. So when you go to podiatry, they can see. When you go to optometry, they can see. And I keep referencing diabetes just because it can be a whole health wrecking ball, right? And so when you go to an appointment within the VA healthcare network, your file opens and they can see all your diagnoses. They can see all your medications. You don't personally have to share those. And it's not about do you think it's relevant or not. So often we go to appointments like, what are you allergic to? And you're like, what does it matter? I'm here to get my toes looked at, And it really does matter. Certain medications, certain predispositions, certain side effects, and all these reactionary things. And in the private sector, you get a referral to podiatry, they don't get access to your file. They get the referral, you got to do a whole other intake. Right? You go to optometry, same thing. You have diabetes, you don't tell them you have diabetes. You miss the checkbox, but you have glaucoma. There's a relationship there. And so I wouldn't say that there's an oversight within VA healthcare, but because they have that centralized database of the whole health that all of the departments can see, it allows VA to be better whole health caregivers. Because the veteran isn't responsible to share things based on what they think is appropriate in that moment. The medical providers can look at everything and extrapolate what they need. And I think that makes a big difference. And I think I think there's when a medical professional takes a position within the VA healthcare system, they go through some PowerPoints about working with the veterans and within the veteran community. But I think the strength in VA healthcare for veteran advocacy is that 40% of their staff are veterans. And so there is a personal passion that they prioritize that's separate from the civilian healthcare networks and insurance programs. And so there's all these nuances to it. And everyone thinks of the big VA as this very elusive being. And what's in reality is that the Department of Veterans Affairs is completely transparent. Everything is available. Every law, every rule, every benefit, it is all in writing. Veterans aren't good readers. They don't take the time. And so they get frustrated because it doesn't make sense the way they think it should. And they navigate private healthcare and they think that's how VA healthcare should be. And there's just a lot of misunderstandings. And there's a lot of, and this isn't an insult, it's ignorance, lack of knowledge. People don't understand how the systems work. But I think because we don't have a base near us and we have such a high population of Guard and reservists who have deployed, who have exposures to just deployment cycles alone, whether they've had toxic exposures or not, the mental stress of serving your country, serving strangers. Most of our first responders, they serve their community or a neighboring community. They're not traveling across the world to protect people they will never ever meet. It's a different mentality. And so I think we need to understand that Hampden County has over 30,000 veterans, right? If we look at the numbers, VA healthcare, only 33% of veterans enrolled in healthcare. That's because not everyone's eligible for it. Some of them don't want it. Some of them already have good healthcare because they came back and had careers and they like the private insurance that they have or the retiree program that they have, which is great. But the reality is our private sector is treating people and doing them a disservice by not educating themselves about that population and about those medical conditions, those predispositions to some of these presumptive toxic exposures, and the resources, right? I go to pediatrician appointments and there's WIC posters and there's food stamp posters and there's housing posters. But when I talked to my son's pediatrician that he had dyslexia and ADHD, she didn't know to tell me, well, Military OneSource has free tutoring services for military connected kids. But there was the state resources for military connected, well, not military connected kids, but tutoring services. So my kid has an option to go to something specific to a military family, which would give him a sense of inclusivity. And she didn't know to tell me that. Now I'm grateful for my work and my exposure, and I know that. Yeah. But I feel if another military family was supposed to go in there and have that experience and not get that resource, that's a disservice. They have an oath and they have an obligation to look at whole health, and they do provide state and federal mandated resources that are open to everybody, but with such a big military population, over what, 275,000 veterans across the Commonwealth. You figure all of them have parents, significant others, children. That family network is 600,000. That's a big pool of people in the private sector that are not getting access to resources through the medical people and offices that they're going to see. They may not call their VSO, they may not go there, they may not live close to the base, but they've got a doctor. So why can't we put those resources at those families' fingertips? I think it goes back to that lack of awareness of why they should, but I think it's along the lines of when the municipalities and the cities and towns send out those voter registration forms, there's that box, have you ever served? Right? And they're willing to volunteer that because they assume there's a benefit to sharing that information. And schools ask that for children. Are you a military connected child? So why wouldn't the medical field also ask that? Clearly there's a gain of that knowledge on how they can treat people and how they can support them. When these service members, stereotypically it's a male veteran, we have a 10% female veteran population, we're out there, but we're going to talk broad brush, right? But when service members go to drill weekends, go on deployment, come home from active duty, they go through trainings. They are handed pamphlets, they are handled the flyers, and those items get folded up, they get put in a uniform pocket, they go through the wash, and then they're in the trash. That information does not get back to the families. And again, in stereotype, the spouses care more about the veteran than the veteran cares about themselves. So the person that needs that information to do the advocacy in the home is not getting it. And for generations, we've tried to pass it through the service member, and it's not getting there. But who takes the family to the doctor's appointments? Who schedules them? Who does the prescription fills? Typically, it's the spouse. So targeting the spouse, whether it's to the pediatrician offices or the whole health office or the primary care or the specialty, should be everywhere. We have too rich of a veteran and military population in the Commonwealth to ignore that. Setting aside the worldly conflicts at the moment, we're not militarily involved with heavy deployment cycles right now. That's kind of tapered off post 9/11. So I would say 2000, 2015, yes, the schools were aware. Military Education Child Education Coalition was going out to schools. They were doing seminars. For example, there's an exercise that they do with the families and with the teachers. And they say, okay, and they draw a big circle on paper and they say, this is the boat. We're going to put 4 people in that boat. And picture it rocking, right? Somebody deploys, somebody hops out. What happens? Everybody readjusts. And they get their space and they figure out their bearings and then they float. And then you got to put someone back in there and they have to readjust. And it rocks the boat and it makes the waves. And it's a little more cramped again. And so those transitions are really hard on children. And that's a very visual description of the tension. You know, I only have to ask one parent. I only have to worry about, you know, if you're a teenager, you know, getting by one mom, not mom and dad, or not dad, you know? And so it changes the dynamic in the home. And now you've got a single parent, so they're spread a little more thin. Older kids have to step up. Little kids tend to, they go through a grieving process. It's very, very similar to that through the deployment cycle. And so there's all these elements. Plus, you still got to pay the bills. You still got to go to school. You still got to go to sports. You still want to engage and keep as much normalcy, but the weight of the responsibilities is now cut adult-wise in half. And so all these things happen, and the schools were really, really good about understanding that. And that's why they ask if you have a military-connected family, so that they can monitor that child, not just academically, but behaviorally. They can reach out to the family for supports. Do you know who your family program office is? Do you have a family readiness group or a key spouse programmer? Are you connected and supported? So what happens in the veteran community is nothing. Because when you're enlisted and you're active or you're guard or you're reserve, you're in this component and you're in this bubble and you have all these supports, and then you discharge and the Department of Defense says, have a nice life, thank you for your service. And you're supposed to just go and be. And parallel to that, running alongside them is the Department of Veterans Affairs yelling at them, hi, we have benefits for you. Except the military has said, stay in your bubble, we'll take care of you, ignore everybody else. As a veteran, pain is weakness leaving the body. Take care of your battle buddy, drink water, suck it up, don't complain, don't go to sick call, right? And so you get into the civilian community and they kind of flounder and they don't trust other entities and they don't trust new people. And the psychological transition for the veteran or the veteran family is so drastically different than a military member in a military family. Because you lose that connection, you lose that camaraderie. And some communities and some states have programs to reach out and get that information and reach out to you. But how much mail does everyone throw away? If you get a letter from somebody you've never heard from before, you're going to trust it? Not likely. Until you've gotten that letter 4 or 5 times and seen that name or that office 4 or 5 times, and you're like, all right, maybe I can trust this one. Maybe I can give it a try. Maybe I know someone that's used them. But building that trust in the veteran community is even more difficult than building the trust in the military community. It lends to isolation, and it just lends to downward spiraling, to be honest, and feeling like you have to struggle, and then you're treading water, and you're just not knowing that there are so many life drafts an arm's reach away. You just don't see them. It's like you're in the dark. But yeah, so what I do in my role, I get a list from the DOD of all the returning veterans, and I send them a little postcard and say, hey, this is who I am, reach out to me if you have questions about VA or local benefits. I work with my school district, and I've gotten permission so that I get the contact information for military connected kids if the parents check the box to share their information with me. And so I send emails, scholarships, summer camps, November's month of the military child. And so I try to make myself as available and consistent so that I become a trustworthy source. But I only work for one town and one county and one state. And I don't know what the solution is, but I know there are steps that industries can take to start filling those gaps, to build that trust and to be that conduit to resources. I think when we talk about trust, the medical community is a community people have to trust, right? They've created these educations and these trainings and this experience, and they've done so much studying, and it's so, no one knows, I won't say nobody knows, but the layperson isn't aware of the extent of that training, right? But we just know it's a lot, and so we trust them with our health, we trust them with our lives. So when they hand us something and say, this could help, this might help, you know, next to the WIC posters, the military one source poster, or the TRICARE poster, or your VSO poster, or whatever it is, if I see it there, the trust is inherent because you have to trust them. So I think if we can build the bridge there, it's a place they have to go, it's a place they have to trust, and it's a step in the right direction. Because of the work that I do, the passion for the advocacy, I sign up for all the studies and all the surveys to have a voice. I've tried to facilitate women veteran events, and it's just low response. Many women don't identify as veterans. It's just a chapter in their life. They compartmentalize it, and it's in the past, moving forward. They also know that there's not many other women out there, and we also come from very male-dominated occupational services, right? MOSs or whatever your job was. Even in the medical fields in the military, it's still very male-dominated just because of the percentage of women who serve in general. And so to do women-only things is challenging because we've never done women-only things as veterans. And then the VA healthcare system is transitioning into being very pro-women's health, women-friendly, I'll call it, supporting the families that come. They're putting breastfeeding rooms on property with signs to say this is a safe place, this is a comfortable place, this is a secure place that you can take care of your family, whether you're the patient or the advocate. I did a study, and my biggest feedback to them about women's health is that I was using private insurance because VA healthcare doesn't encompass the family. I still needed private insurance to take care of my kids. So I got my women's health from when I was a child, going through puberty and adolescence and then into women's health. I went through the same office because I had the insurance and I just went there. And I never recalled my primary care at the VA saying, did you know we have women's health providers? They just said, do you have a provider? And I said, yes. And they said, okay. And it wasn't until, and I've been using VA healthcare since 2005, it wasn't until last summer, 2024, when they asked me, do you have a women's healthcare provider? And I said, actually, mine retired. And they said, oh, did you know we have one? And I said, why would I have known that? No one's ever told me that. They didn't share further information other than asking me if I had one. I didn't know they would offer me one. I thought they just had to check the box to make sure I had something. With all those other annual screenings, instead of just saying, do you have one, say, did you know we offer that? Did you know that was a service the VA Healthcare Network provides for us now, here locally in Western Mass? And I go to seminars and the scales are not balanced. VA Healthcare in Vision 1 in all of New England does not have mammography. It is not affordable to purchase the machine because it is so expensive for such a small population. It just doesn't make sense with taxpayer dollars. So that is a community care referral. But that's not something I knew I could get through the VA because once I said I had an OBGYN in the private, they just said, okay, never mind. And so how many women that are in VA healthcare could have access to mammography services at a much more affordable entity? There's, you know, the copays versus, and the referrals versus when you go for mammography, even though it's preventative, not all insurances cover that. Or there's a significant copay. So just because they said, do you have women's health care over here and never offer it over here, that's a disservice. I think it's progressing. Again, it's a societal perspective change. You know, the women veterans are using healthcare more. The cause of it, the culture, the empathy, the understanding, the lack of an expectation that when I walk into the clinic that I'm not there to pick up my husband's prescription. On your intake form, when you go to the doctor, if you haven't been there in a year or more, you got to do an update health form. So just add that box. Are you a veteran? Are you in a military connected family? You know, have 2 boxes. I don't care. But that way, you can start screening for that information, whether it goes into a database or not. When the doctor sits down, or the nurse who's setting up the triage room, because the doctors don't come in for an hour later anyway, they can ask that question. But with that, they need to understand why they're asking the question. Did you serve in Camp Lejeune? Were you exposed to Agent Orange? Nuclear iodizing radiation? Were you a prisoner of war? Did you serve overseas in Desert Storm or more recently for the burn pit exposure? And if they say yes, guess what? The VA has a fact sheet that you can print out that has all the corresponding presumptives on it. You don't have to memorize it. I'm not saying they have to go take a training or they have to learn something, but just prepare themselves with the tools that are already available, just to be better care providers. I've never had a civilian approach me about it, but it's a conversation I have with all the veterans I sit down with. Again, veterans, they don't advocate well for themselves. They take care of everybody else. They'll be fine. They'll suck it up. And so oftentimes I can get them to advocate when I tell them, well, this could lead to you being a better caregiver to your family, caretaker to your family. You can financially support your family. And that's usually how I can get most of that generation of veteran to say, wait a minute, what? And so I literally print out the presumptive list and I hand it to them and I say, share this with your doctor. Let them know that you are more susceptible for this laundry list of conditions so they can be more proactive with their diagnostics. Doing these claims and learning these things and seeing the trends, I'm pleased that I've been able to help people. So one of the conditions associated with, it's actually Camp Lejeune and Agent Orange, is Parkinson's and Parkinsonisms, and it often starts with an almost unnoticeable tremor. And I've had people come to me and they show me their discharge and I look at them and they're like, I have nothing on that list. And I hand them the paper and I see and I say, okay, I don't want to startle you, but if you look on that list, one of those conditions includes tremors. I said, so if you're inclined, I would recommend you contact your physician and have a screening because you're more at risk for this. 7 times I have said that to veterans. 6 out of the 7 times they came back 2 weeks later and said, I have a diagnosis, early onset Parkinson's. Not only could we service connect them, increase their income, enroll them in VA healthcare, they had early diagnosis, which leads to more comprehensive treatment and slows the progression. When we work with veterans, I will say 50 years and older, I always recommend bring your significant other with you because they will be much more honest with that doctor than you are about your symptoms, about how you're sleeping, about your temper, about how you're eating. You're going to walk in there and say you're fine. Let someone who loves you tell the real picture. It's not a new degree. It's not a new class. It is just caring enough to see that someone's experience could negatively impact their health. They already do it with smokers. They already do it with people that are exposed to asbestos. Why aren't they doing it for people that served in the military? Can we start to give providers a reason to be curious, like you said? Can we give them the tools to have it, like hip pocket training, a very military term? Can we give them a couple of files that says, hey, if they reference burn pits, overseas, deployment, Camp Lejeune, Agent Orange, Vietnam, maybe we can pull out a piece of paper and have a conversation, and then you know what to look for. May not be the only things they have, but more susceptible. I don't know that, I don't want to say that they don't want to. I do believe they want to. I don't know that they're given the parameters to. And unless they're going to take it upon themselves, we gotta circumvent this and go to DC and start trying to figure things out. I spend the majority of my day just educating people on what's out there, what the possibilities are, what the potential is. I often have to work with my veterans and say, listen, VA healthcare, private healthcare, it's not like DoD healthcare, right? DoD healthcare, what happens? Annually, or it's deployment cycle focused, it's round robin. It's go through the stations, and they are going to check you top to bottom, front to back, inside and out, right? They're going to say, check your eyes, check your ears, here are your vaccines, turn your head and cough if it's appropriate, don't tell them you're crazy, and get out. When you go to private healthcare or VA healthcare, you walk in there and they say, how you feeling? And if you say, I'm fine, they're going to believe you at face value. So you have to advocate for yourself. It's just the way the systems are designed. They have a duty and have taken an oath to take care of anything you present to them. But if you don't present it, they certainly can't treat it. And on the flip side, they have a duty to stay abreast of medical advancements, new studies, new researches, new nuances, new medications. So should it be part of that, the veteran community? I think it should. With such a robust veteran population, less than 0.5% of the population is serving right now. But nationally, we have an over 10% veteran population. That's a big chunk of the people. They should be able to get quality care and educated care, whether they're at their VA or not.